All right, guys, it's just about 7:05 now. Thank you so very much for joining us this evening for the first of our CEU series focused for athletic trainers specifically. Tonight, we're going to be hearing from Dr. Erin Reynolds. She is out of the Baylor Scott and White Sports Concussion facility at the Frisco Star. She's going to be presenting tonight on the new science of sports concussion and then clinical profiles and targeted treatments for active recovery. If you guys have any questions, we will have a question and answer session at the end of the program. If you want to direct those via the chat or place them in the question and answer poll room, I will facilitate those and Dr. Reynolds will be answering those for you guys. So before we take up too much time, I will go ahead and introduce Dr. Erin Reynolds.
Thank you very much. Thank you everyone for attending tonight. It was unfortunate we had to postpone, but I think it was fortuitous that now we're in March and it's Brain Injury Awareness Month. So this is good timing. I'm going to start off with just, a little bit of background about me, because I think there are some people on here who I haven't had the opportunity to meet over the last few years that I've been here in Texas. So to give you that background, I am a clinical sports neuropsychologist. So what that means is that I have a doctorate in clinical psychology, and I then did 3 years specializing in neuropsychology, all with the Veterans Administration just outside of Boston. And during those 3 years, I was mostly specializing in the polytrauma unit. So working with younger veterans who had sustained multiple blast injuries, so TBI with comorbidities of PTSD and other health conditions. And it was during that time that I realized that we were doing a lot of assessment, but we weren't doing a lot of treatment. And you know, the VA is a large system. It's hard to affect change in a system like that. So I wanted to seek out some specialty training that would help me to understand, what do we do with athletes or veterans or anyone really who sustains a brain injury? There must be a way to treat it. And so I sought out some advanced training, and I wound up doing an advanced fellowship in sports neuropsychology at the University of Pittsburgh and UPMC in the sports concussion program there. That was then and continues to be the largest clinical and research concussion program in the world. So I was very lucky to be trained by Mickey Collins and others in that program. And I went on to be faculty and the fellowship director of that program for 5 years. I was then recruited to Frisco in 2017 to start the Baylor Scott and White Sports Concussion Program. I was actually employed through BSWIR initially, and the program has grown exponentially in the last 4 years. I'm going to tell you a little bit more about the program as the talk goes on, but we are now located at the Star on the 8th floor. You're all welcome to stop by at any time into our facility. Outside the work I do with youth and high school athletes and college athletes, I'm also the team neuropsychologist for the Dallas Cowboys, the WNBA Dallas Wings, the Texas Legends, and for a very short time, the XFL Dallas Renegades. Okay, so tonight, what we're going to talk about, we're going to do a very brief overview of pathophysiology. We're not going to get too in the weeds with that because I really want to focus this talk on treatment and things that are really applicable to what you do on a daily basis. We are going to review this new on-field assessment tool that I think some of you have seen, and we will be sending out to all of you after this talk. I'm going to describe the updated clinical profiles model. So I will start with the old profiles model to do a refresher, and then I will present the new version that was just published a few years ago. And then we're going to talk about some targeted active treatments using that clinical profiles model. We're going to do a demo of the VOMs. You're going to get the experience that my telemedicine patients get by doing this virtually. And we're going to do a bit of a deep dive on behavioral strategies to support recovery. We really rely on behavioral strategies as the foundation of treatment in our clinic. And so I want to give you some ideas of things you can use in the schools or with the teams you work with to support your athletes through their recovery with behavioral strategies. And then finally, I'm going to give you some research updates. We have some really, I think, some really exciting things happening at the STAR. We have started the concussion research program. So I'll give you a little taste of what we're starting to look at there. Okay, so typically when I describe concussion to patients, I use the old egg analogy. So if you had a raw egg and you shook it, the yolk is your brain. That's what happens to your brain when you get a concussion. But essentially, as you probably all know, the word concuss comes from the Latin word, which means to shake violently. And the injury occurs when your brain shakes hard enough inside your skull, either by direct or indirect force to your head. When that happens, it affects all of our brain cells. We each have about 100 billion brain cells, and all of those brain cells have a cell membrane that is designed to keep potassium inside the cell and keep calcium outside the cell. And when the brain shakes hard enough, all of those brain cells start to stretch out and twist, and that cell membrane gets very thin, and the potassium starts to leak outside of the cell while the calcium rushes inside the cell. And this creates a toxic environment in all of the brain cells. And so the brain immediately kicks into repair mode. The repair process or the recovery process takes time, and it takes a significant amount of energy. At the same time this is happening, the blood vessels constrict, so there is reduced blood flow to the brain, and the blood flow is what brings energy and nutrients to the brain. So not only does that cause some headache, but it puts the brain in this state of energy crisis. And so we talk about recovery process as being in this constant state of energy crisis. And through some of the behavioral things that I'll talk about a little bit later, we really try to maximize the amount of energy the athletes have for healing as they go through recovery. So just general overview, concussion is a complex pathophysiological process. As I said, it could be a direct force to the head or an indirect force to the head. We see more indirect forces in sports like hockey, where they would get thrown into the boards, or wrestling, where they sometimes take a funny hit and don't actually hit their head. It is a neurometabolic dysfunction. So that's that chemical exchange. It's not a bruise, it's not bleeding, it's not a lesion. And you'll have normal structural findings. So it's never going to show up on CT scan or MRI. I'm sure this is just review for everyone, but just so we're all on the same page. You do not have to lose consciousness to have a concussion. We know it's a very small percentage, less than 10% of athletes who will actually sustain loss of consciousness. And symptoms are categorized typically into physical, cognitive, emotional, and sleep-related symptoms. We're going to go into symptoms a little bit more here in a minute. But recovery is a sequential process. So we know that not everyone recovers at the same rate. Not everyone's going to recover in a linear progression, but it is sequential. So this is one of the reasons it's so important. And we emphasize seeing the athletes often as they're going through the recovery process. And this is one of the reasons I love working with athletic trainers, because once my patients leave the office, I really rely on athletic trainers to be my eyes and ears in the school and on the field, and to help kind of update where the athlete is in this process. So signs of concussion, these are just the signs that a concussion may have occurred. Obviously, appearing dazed or stunned, any disorientation or confusion, moving clumsily, brief loss of consciousness, vomiting, any amnesia before or after the event. And then the symptoms. So like I said, we still categorize them in these 4 categories. This has been done for, gosh, decades now, and it works, so we stick with it. Every time I assess a athlete with a concussion, I'm thinking in these 4 circles, just to make sure I'm capturing all of those symptoms. So the physical, the headaches, dizziness, nausea, any photo or phonosensitivity, blurred or double vision, sleep after obviously the first day. Are they sleeping too much, too little? Any problems falling asleep? Are they unable to sleep? The cognitive symptoms with fogginess, I think, is arguably could be in physical or cognitive. So when I describe fogginess to my patients, I'm not actually talking about fogginess in terms of clouded thinking, more talking about the feeling of being like one step behind yourself or a little bit detached. So sometimes I describe fogginess as feeling a little bit out of body. And if they're having that feeling, I would more consider that a physical sensation than a cognitive symptom. And then of course the mood symptoms, so irritability, sadness, anxious, feeling more emotional. I work with mostly teenagers, so it's parents always laugh when I ask these mood questions. And so we always emphasize that this is a significant change from their normal mood. If the person is always very irritable or always very anxious and they're staying at that level of anxiety or irritability, that's not something we'd be concerned about. So in terms of the on-field concussion assessment, the rule that I firmly believe should be upheld with all athletes at all levels of play is any on-field finding means no return to play. So what does that mean? Is just a headache enough to remove a player from competition? Obviously, this is a judgment, and as athletic trainers, you have intensive education on how to assess on the sideline for concussion and everything else. But we have seen so many athletes with a delayed onset of symptoms that I really think it is best to err on the side of caution. And I say that as someone who I don't consider myself super conservative when it comes to treating concussion. I think you'll see as we go through here, we actually employ a very progressive, active recovery approach. But I've seen too many times someone come off the field and just say they have a headache or say they got hit with the ball right here and say, well, it just hurts there. And then they get returned back to play. And then 3 hours later, all of the symptoms come out. So it's a liability issue and it's a safety issue. But if I were you, I would probably just keep them out if there were any indication. If anyone could look at that symptom checklist and question why the player was returned, I don't think it's worth it. So in your on-field evaluation, obviously we're evaluating signs and symptoms. Are there any present? Some form of neurologic exam. So that's usually in mental status testing, that's usually a brief memory exam, looking at their eye movements. If you have an assessment you can use, we're going to talk about the VOMs later, which is not really validated for sideline, but can be used. But doing some form of a check-in to see if there's anything abnormal, including balance, and then determining if that athlete has to go to the emergency room. So I actually had a mom just today ask me, she has a hockey player and she did not take him to the emergency room, but then his friend had a very similar injury and he was taken to the emergency room. So she wanted to know, well, what should I do? And so we had the conversation that going to the emergency room would only be to rule out if there was something more serious going on. So is there bleeding? Is there swelling? And unless you see something like in this list of red flags on the field, most of the time the decision is going to be not to go to the emergency room. But I think it's really important that the parents have this list of red flags to be able to check over the course of the next 24 to 72 hours. And so we have in our program these little pocket guides, which if you're interested in having some, you can contact me and I'm happy to send you some. And the pocket guides are designed for the parents to have in their wallet or their pocket, and hopefully never pull out, but to have in the event that their child has a concussion. And it has this list. And we also, I think the next slide, I'm going to show you this new assessment tool that we included these that you can also implement. Wonderful. Okay. So this is a new assessment tool. And again, if you haven't seen it yet, you will be getting it in a PDF fillable. If you do work for Baylor Rehab, which I assume you do, I think this was sent out by Kendall and Lydia. This is a trifold. So this is just a PDF of it, but it's you have a hard copy version of it, it's a trifold. And so this is the inside of the trifold. This was designed by myself with significant input from athletic trainers. So specifically Corey Smith, JD, Shields, Kendall, Lydia, everyone gave feedback on this as to how can we create a tool that is more streamlined than the SCAT-5. It captures all of the information we need from an administrative standpoint. So the information you have up at the top there with the demographic info, and then information that we can gather that's going to cover our bases for neurologic exam and mental status exam. And so this is what we came up with. It's pretty easy to fill out. You're going to make simple notes about the injury itself under mechanism of injury there, some brief orientation questions, a 3-word memory recall, a little bit of assessment about their memory for the injury itself, do the months in reverse order, digits backwards, go through their symptoms, and then do a brief neurologic exam looking at their cervical range of motion, any weakness in extremities, numbness or tingling, and tandem gait, and then go back to the delay. It's all right here. So you would literally just go through, and if you have a hard copy, you would be writing this in. And the idea, if you're using a hard copy, is then you can take a picture of it with your phone or tablet. So you have all this information, the pictures for you, and then you hand this to the parents. So you see there, it has the critical red flags they're going to look for on over the weekend. It gives our action plan, which is information about how to make an appointment with our clinic. And it'll have all the information you filled in that they can then bring with them to us or to whoever they see. And the doctor or the neuropsychologist will be able to review this on-field assessment. The other side of the tool, so this would be the back of the tool, you have some space there to write in any comments. And it also goes through our at-home behavioral regulation, which I'll go through a little bit later, and some things the athlete should not do, like taking ibuprofen and driving. So we've had a really great response to this tool so far. Everyone who is using it seems to like it. I think we've distributed about 3,000 of them already. And like I said, we also have the PDF fillable version. And if you're going to use it PDF fillable version, you can also just take a screenshot and then text it to the parent. And then they have all of this information. So I'm hoping that this is helpful for you. This is I consider this a work in progress. So if you do get your hands on this and you use it and you see something that is missing, or you think that you have an idea that could really improve it, please reach out to either myself or Corey or someone, and we will definitely take a look and see how we can modify this to better suit a wider range of people. But we'd love if everyone tried it out. Okay, so I want to touch base on this. This is now old data. So we're talking probably like 5 or 6 years ago. But so like I said, I did my specialty training in sports neuropsychology in Pittsburgh. So the UPMC Sports Concussion Program is where the impact test was developed. It's really a hub, and it has been a hub since the year 2000. So it's now been there 21 years. And because of that, Pittsburgh is a very isolated bubble of concussion knowledge. So many kids there have baselines. I mean, everyone just kind of knows what to do because it's been drilled in their heads for literally 20 years. So at some point when we were there, when we started seeing more out of town people coming in, some protracted recoveries and folks who were just not getting great care across the country, we wanted to really get a pulse on what's going on outside of Pittsburgh. How are people viewing concussion? And so we commissioned this Harris poll, and they polled just over 2,000 US adults. And the results were really surprising to us. I'm just going to highlight a couple of them here. So 24% of that population thought that a concussion would change their lives forever. 72% believed that, number one, there was damage, brain damage, but number two, that brain damage was permanent. And 25% of parents said they would not allow their kids to play contact sports due to fear of concussion. And so this was right around the time that the media was very hyper-focused on CTE. There were a lot of prominent athletes being diagnosed with CTE, and there was a lot of talk everywhere you turned, focusing on CTE. And without denying CTE was a problem, we really wanted to start talking more about treatment, because the reality is kids are going to keep getting concussions. And if people are afraid of them, what are they going to do when their kid gets a concussion? How are they going to know what to do? So we really took this information as like, we need to change this conversation. So like in all the media leading up to the Super Bowl, I don't want them to sit around and talk about CTE and the terrible long-term effects of concussion if they're not also going to talk about, but here's what we know about concussion now, and here's how we can treat the injury now, and we can start to prevent those long-term things from happening. So that was kind of the mission that came out of this Harris poll. So right around the time this poll came out was also when we were starting to this massive shift from like rest to activity. And you know, Texas is very progressive and advanced in a lot of things, but there's also a lot of pockets in Texas that I've experienced now that are still a little bit behind the times in terms of what we're doing with concussion. And so I just want to talk briefly about this theory about rest with concussion. So we used to prescribe strict rest. A lot of people still prescribe strict rest. I still get these referrals today that the kids are taken out of school for a week and they've been, you know, in the dark, no technology, things like that. So we used to prescribe that because we know that healing from a concussion takes a lot of energy. There is an increased metabolic demand and there's limited energy to supply that demand. So the idea is, well, if you just go to bed, you're going to preserve your energy. And if you're in bed, you're going to have a much lower risk of being re-injured from playing sports. So therefore, it makes sense that you should probably just go to bed. And this was just kind of how we thought about it. It really wasn't studied. And interestingly, the non-sports brain injury research from quite a ways back was really focusing on neuroplasticity and resilience and introducing activity early. But the sports concussion world was not. So there's very limited evidence that rest, I mean, there were like 2 studies that showed rest was beneficial. And so in 2013, that was the first time that any kind of national body made a statement that there was little evidence about this. This was something everyone just kind of did. So we actually know, as we've started looking at that right around that time, 2013, that when you take an athlete, especially middle school, high school, college age athlete, and you put them in a quiet environment, you take them out of school, out of sport, out of social circles, they don't do well. They become depressed, they get irritable, they get hypervigilant, so they're constantly focusing on their symptoms. You know, always thinking about, sometimes we have athletes say, well, I only have a headache when I think about it. And that tells you that there's some of that hypervigilance going on. So there was a study that came out in 2014. Noelle Zuckerbraun is a pediatric ER doctor. And her study took 2 groups. So 2 groups of kids that came through the ER with concussion. One group, she gave standard instructions, which at that time were to go home and rest. And then the other group, she wrote instructions that said, slowly get back to normal activity as soon as possible within the first few days. And when she checked back in with them 2 and 3 weeks later, the group that was told to go home and rest had significantly higher symptom reporting than the group that was told to get back to normal activity. So there's definitely something there about telling someone that it's good to get back to their normal routine. However, it really wasn't put out in any major consistent way until about 2018. So in 2018, the 2016 consensus statement was finally published. The CDC guidelines were updated, and the American Academy of Pediatrics clinical report on sport-related concussion in children and adolescents came out. And all 3 of these said strict rest may not be the best plan, and that after a period of 24 to 48 hours, we should start to slowly increase normal activity as tolerated. So the question is, what took so long? What took us decades of resting kids to take this shift? And it's really back to, we hadn't been talking about treatment. We really still aren't. We are more now. But concussion treatment was really absent from guidelines and research at that point. It was really research, and it continues to be a lot of research on prevention and epidemiology and things that don't really solve the problems that we need to have solved. So in 2015 in Pittsburgh, we hosted a meeting. It was called the Targeted Evaluation and Active Management Approach to Treating Concussion, shortened to TEAM, the TEAM approach. And this was the first meeting. So this was built in the idea of like a consensus meeting. So there were, I think, 37 participants, neuropsychologists, physicians, physical therapists, athletic trainers, all different names you would recognize. All different folks came together to talk about treatment of concussion and to come to some agreement. So there are 17 statements of agreement. You can look up the reference if you're interested in reading all 17. I'm just going to highlight a couple here. But number one, and this had full agreement, it's that concussions are characterized by diverse symptoms and impairments in function resulting in different clinical profiles and recovery trajectories. So what does that mean? That means that a concussion is not just a concussion, and we cannot just treat every concussion the same. So we identified at that time 6 unique clinical profiles that would emerge in someone's recovery. And so just to give you some context, when someone gets a concussion, the first 48 hours are really the acute, they're the worst of it, right? So the first 48 hours, most people are gonna have cognitive problems, they're gonna be tired, they're gonna look migrainous. The first 7 days is really the acute healing stage. So every day during that 7 days, there can be significant variation in what we're seeing with symptom profiles. But really after day 7, you start to see these very specific profiles emerge. And each of these profiles has a very specific set of symptoms and a very specific set of treatments. So I'm going to go back for a minute. So let me just real quickly run through them, and then we're going to break them down in a minute. But the vestibular profile, so that's going to be dizziness, difficulties with balance, feelings of motion sickness, nausea. The ocular profile, so any blurred or double vision. So sometimes there's a problem with their eye movements. Sometimes this comes across as complaints about reading. The cognitive fatigue profile, so with that, difficulty concentrating, remembering. There's usually a low-grade headache. If they're in school, they'll complain that they kind of get worse as the day goes on. Posttraumatic migraine is exactly what it sounds like, and we're going to talk a little bit more about migraine in a minute. The anxiety profile, again, would be mood changes beyond what would be expected. So if it's slight elevation in mood, that's expected, especially with this injury, but these are significant changes in mood that are causing concern. And then there's the cervical profile. So you'll see there's some changes that I'm going to talk about in a minute, but that cervical profile was to capture the concussions that either included whiplash or that had some cervicogenic dizziness that were contributing to the overall recovery. I'll get into that just a little bit. So the second statement of agreement, once we established these profiles exist, was that matching targeted and active treatments to clinical profiles may improve recovery trajectories following a concussion. Meaning, if you can identify what profiles were present in that specific person, you could then tailor the treatment to treat each profile rather than, throwing spaghetti at the wall and hoping whatever treatment you're prescribing is going to stick. So when you look at these 6 profiles, they each have their own treatment. And the most important thing, like we could talk about this for hours, but I just want to kind of highlight almost all of these profiles have exercise as an actual treatment, prescribing exercise. The only one that doesn't is the ocular profile. And the reason for that is because if someone is purely ocular, so they don't exhibit any of the other profiles, which is very rare, they're typically able to work out at full capacity without any problems. If they don't have a vestibular component, they don't have a migraine component, we can usually get them back to full non-contact exertion. And so exercise isn't really the therapy or the treatment, it's just something they're able to do. So looking at the profiles by symptom cluster, so like I said, each profile has its own set of symptoms. And if you start looking through this, what you'll notice is some of the profiles have overlapping symptoms. So when someone is dizzy, it's most of the time going to come from their vestibular system, but it could also be coming from migraine. It could also be coming from, as I said, like cervicogenic dizziness. Fogginess can be attributed to vestibular or cognitive or sometimes migraine. The frontal headache we could see with ocular or vestibular or migraine. So it's really I don't want to say it's complicated. It's real systematic to pull these apart. But every symptom that you ask about, there has to be follow-up questions to really figure out, well, where is this coming from? What is the cause of this? And because if you don't find the cause of it, you really can't treat it. So speaking of that, the current symptom inventories that we use, so this on the side there, that's just the PCSS, which that one I think is taken off one of the scats, but that's the symptom scale we use on impact. And I mean, we use it with everything. So a 0 to 6 scale and 132 symptoms. It's a useful scale for sure, but it's really not specific enough because it's really looking at the global symptoms. So again, we're asking, do you have a headache or pressure in your head? But we're not asking where on your head is it located? What activities make your headache worse? What time of day is your headache worse? And those are all the questions that help us get into the profiles. And the emphasis here is on the total symptom score, right? So when you get your impact printout, it gives you your composite scores, and then it'll say total symptom score. And without understanding where those symptoms fall, that it's kind of a meaningless number. So the approach that we use now, that scale, it does not reflect these emerging conceptual models where we're really starting to get into the profiles. It also really doesn't get into any vestibular or ocular or really anxiety. I mean, it's so general. Or do you feel dizzy, blurred vision? I mean, that could be from anything. And so we haven't been asking the right questions to assess the clinical profiles. So that's important because if we identify the clinical profiles and how they overlap, we know that we can have improved outcomes, improved recoveries. We can implement earlier treatment protocols that will help that athlete get better faster. And if we're going to use this model, we really need to be assessing in a systematized way. So for years, we've been using this model and just kind of piecing together how we're asking these questions. So in 2019, the profiles were reimagined. And so the profiles went through some analysis. I don't know if you can see that. I'm just going to close this for a minute. So these are the modifiers here. But we took cervical out. I say we. I was part of the first iteration of this model. I was not part of this iteration. That's okay. So we took cervical out because cervical is really not a profiled concussion. It's really something different. And so, you know, I always ask very specific questions about neck pain and things like that. But as a neuropsychologist, I'm not assessing that. So cervical is taken out. And if there's any indication there's a cervical issue, that's being seen by my sports med partner. But we have the 5 profiles, and then cervical and sleep are considered modifiers. So what that means is it does not matter what profile or profiles the athlete presents with. If there is cervical involvement or if there is any sleep dysregulation, it's going to negatively impact what's going on with the profiles. So it's important to assess for those things and understand how they are contributing to the general profiles. I will also say, I kind of alluded to this, but most of the time, if not, I mean, like 98% of the time, the person's going to have more than one profile. And so it's important to identify their primary profile, but then also their secondary. And if there's a tertiary, identify that one as well. Oops. So through this reiteration of the model, a new screening tool was developed with 29 items that were evaluated, revised by a team of clinicians who ask these questions on a daily basis. And that tool is called the CP screen. So it's the clinical profile screen. And so we've been using it in our clinic now for about a year. We got an advanced copy of it. It's now been published. And it's really nice because it adds, so for the anxiety mood component, it adds questions. For the migraine, you know, do you have a headache upon waking? Is your headache accompanied by nausea? Is it accompanied by sensitivity to light or noise? These are questions beyond what the PCSS asks. And so all of these in yellow, those are new questions. Those are additions. So I do give the PCSS, I still give that, but I'm giving this in addition to it so we can get all of these questions. And so that's 18 new items that can help differentiate what's going on. And then for the modifiers, it's adding these, so the difficulty staying and falling asleep, and are you having difficulty moving your neck? And so in total, it's 21 out of 29 items are new. And well, this is just what it looks like on paper. So when we have athletes come in now, they fill this out at every visit, first visit through last visit. And they just, check none, mild, moderate, or severe if they're currently experiencing them. That's the back of it. And then there's some calculation that's done, and this spits out what, according to those answers, would be their primary, their secondary, their tertiary, and any modifiers. So the caveat to this, this tool is so helpful and so important from a research perspective. That's why we really started using it, so we could use this data in our research. But it does require clinical judgment. So I have found that it's not perfect, and that sometimes I don't agree with what it spits out. And so it's not the end all be all. If it tells me that they have a primary ocular problem, secondary migraine, third anxiety, and I know that anxiety is far and away overtaking the other ones, I'm going to put anxiety first. So it does take some deep understanding of what you're doing, but it is such valuable added information that I think it's a really great tool to have in your back pocket. All right, so obviously, there's lots that goes into this concussion assessment. What are we looking at when they come in through the clinic? We start with a clinical interview. I'll go through that just very briefly, but we're always doing cognitive testing, vestibular ocular motor, symptoms, and some form of exercise. And the exercise either happens in the clinic or in the schools with you guys on the field, not always in our clinic, the exercise piece, but it really takes a team. So I'm a firm believer that this is not an injury that should be treated in isolation, whether you're a physician or physical therapist or a neuropsychologist. It really takes more than one lens to see the concussions, even the easy concussions, the one that recover really quickly. There's a lot of nuances to it. So I'm a firm believer in the team approach. Our program here in Frisco, this is the model that the program was built upon in our clinic. In that yellow, so that yellow is kind of like the epicenter. So in our clinic, it's me, the neuropsychologist. I kind of consider myself the quarterback or the point guard of the clinic. So all the concussions filter through me. And then, and my referrals come mostly from athletic trainers, but also from other PCPs and pediatricians and EDs. And then through my assessment, I then refer to my ancillary services, so vestibular therapy, or exertion therapy, or sports medicine, things like that. So this is a good model for concussion clinics. It does not have to be neuropsychology in the middle. I learned very quickly when I got to Texas that neuropsychologists can't clear UIL athletes. So we have our primary care sports, our sports medicine doctor in the clinic to help with that. But I think all of these components are important pieces to a successful clinic. So just to give you a little background on our current concussion clinic faculty and staff, we are small but mighty. We have grown a lot since 2017. It started with me kind of in a closet in a PT gym, and now we have a nice 6 exam room office space with a small PT gym. So I'm the program director. Dr. Keston Robertson is our PM&R sports medicine physician. So he was fellowship trained at JPS in Fort Worth, and he started with us last year. And he works with the DCC and some other groups. He's wonderful. He does all musculoskeletal work. And so he's there to support me with the concussion piece, but he is really focused on sports medicine, musculoskeletal. Kayla Cover is our vestibular physical therapist. I recruited Kayla from Pittsburgh, so she completed a fellowship at the University of Pittsburgh, and I recently found out she is somewhat of a unicorn in Texas. So she's one of only 9 with her level, 9 people in the whole state of Texas with her level of training in vestibular therapy for concussion specifically. And she also has trained in exertion therapy. So she's awesome. She and I really tag team these complex protracted recoveries. We do really well with The kids who just haven't gotten better, and it's been a long time, we work together really well to get them back up and running. So she's awesome. And Caroline Curtis is our athletic trainer. She's been with us for a few months now. She's also awesome. I'm going to give you her email address at the end of this. And she's the go-to to get kids in the clinic, or if you have any questions. Okay, so I'm looking at time. I'm going to go through this pretty quickly. Our clinic eval, it's 3 components with a 4th add-on if we need it. We do the clinical interview. We do impact testing in our clinic. We also have other tests that we can use, but that's kind of our bread and butter. Vestibular ocular motor screening, the VOMs, which I'm going to show you, and an exertion eval we can do. We sometimes do those in the clinic, and we sometimes partner with Sports Academy, who is our sports performance group, to implement that. It's really important that all athletes leave with a very clear diagnosis and prognosis. So even when you get through the whole evaluation, sometimes they're still unsure if they have a concussion. So it's important for them to know that. And we give very detailed treatment plans. So we go through the behavioral strategies, any rehab they need, any academic accommodations, what exercise they can and can't do, and any return to play expectations. So let's see, the clinical interview. I think the most important things in the clinical interview are understanding someone's risk factors and understanding their symptom clusters, because those 2 things can really help to determine the treatment plan and the length of time it's going to take them to get better. So in terms of risk factors, we're always looking at age. We know that the younger the athlete, the longer they will likely take to get better. We know that females take longer than males to get better. Anyone with a history of migraine, anyone with a history of learning disability or ADHD, anyone with motion sensitivity, and prior head injury if treated. And that's important because if you go to the research, you're going to think, well, if I get 1 concussion, I'm just going to keep getting concussions. And that's not actually the case. Most of that research was done before we understood how to assess and how to treat concussion. So if someone's concussion is treated appropriately and they heal completely, they should not be more vulnerable moving forward. And so the risk factors load into those profiles. So back to those 5 clinical profiles. If I see someone with a strong history of motion sickness, even if it's in that first 7 days, I'm going to be looking out for any kind of vestibular dysfunction because I know that loads into vestibular. Anyone that has like a family history of lazy eye or cross eyes, that's going to load into ocular. So the risk factors are important to understand as you're starting to figure out what might be next in their trajectory. Like I said, we use impact. We have a number of tests in our clinic. We have sway balance, C3 logics. I have a number of paper and pencil based tests that I can use, but typically we're using impact. It's really important when you have concussion. We still see kids who have seen pediatricians or general sports med docs who haven't done any kind of neurocognitive assessment. And so at the very minimum, having some form of memory assessment, some form of processing speed and reaction time is really important. But what tests they use isn't as important as actually looking at this. We know that that kids will not always recover fully. When they say they're fine, their cognitive functioning might not be 100%. So this is something we always want to be looking at. Looking at the timeline, I am still a proponent of baseline testing. I know that's a conversation that comes up a lot right now because the last consensus statement said you didn't really need to do it. Sure, we can see people that don't have a baseline. We do it all the time. But the group baselines are going to catch those kids who either have attention problems or learning problems that maybe haven't been identified. And so if I have a kid that clearly has ADHD and has never been diagnosed with ADHD, it's helpful for me to see their cognitive data before when I'm trying to get them back to some semblance of normal. So I do think baseline testing is important if you can do it, and getting them into the clinic as soon as possible. I, at this point in my career, think going to the specialist out of the gate is the best way to do it, because the more time they waste in a general practitioner's office and they don't have a very clear plan of what to do, the longer their recovery is going to be. So for the VOMs, I'm going to go through this quickly. And there's references we can send. I'm always happy to go through this a little bit more in depth if anyone has any questions. But we always look at the vestibular system. You know, I like to show this slide because if this slide makes you feel sick, you might have a sensitive vestibular system. It's hard to look at. The vestibular system, for a long time, we thought of it as balance. As athletic trainers, you know, we've assessed balance pretty extensively for decades, but this is really looking beyond balance. So the symptoms of dizziness, fogginess, nausea, environmental sensitivity. So those two pictures for kids who are in high school, like being in a crowded hallway as the classes are letting out. If you have a vestibular problem, you're gonna be overstimulated and not be able to handle that. The same as going down a grocery store aisle or being at Target. So really tapping into underlying vestibular issues is important. And so I use the VOMs, every single patient, every single visit, I do a VOMs on them. If you're gonna use it for research purposes, you use a template like this. If you wanna use it more casually, I think there's still value to it. But there are components that I will show you. We're actually filming a video demonstration of this in a few weeks. I wish I had it for you now, but I don't. I have these pictures. So the first part of the VOMs is looking at smooth pursuits. So we're just doing a basic H test. So I would say, you know, if you were in front of me, follow my finger, and I'm going to make sure I'm hitting all four, up, down, and you can go diagonal if you want to, but really the four corners are important to make sure that they're following your finger, whoops, and their eyes are able to track. For horizontal and vertical saccades, so my hands would be a little bit further out normally, but you give them targets. It's important that you give them targets to look at. And you're gonna have their eyes, so I'll do it in the screen, go back and forth, and you have them go 10 times. So 1, 2, 3, 10 times. And then you go up and down, you have them go up and down. And every single time you're assessing, how bad is your headache? How bad is your dizziness? How bad is your nausea? How bad is your fogginess after every single exercise? Looking at near point, I don't have a pen I can show you, but you hold an object out in front of your face, you bring it in as close as you can, and they tell you when they see double. And you can see there she's measuring. So 0 to 5 centimeters is normal. Anything beyond 5 centimeters could be considered abnormal. These next two are probably the ones that if you're going to do anything on the sideline, these are going to be the most telling. So this is the VOR. You don't have to use a target, you can use your thumb. So you have them stick their thumb out in front of them like this. And for the first one, they're going to stare at their thumb and they're just going to go side to side. And again, they're going to do it 10 times. And you're going to assess their symptoms. And then for vertical, up and down 10 times and assess their symptoms. And then for VMS, for visual motion sensitivity, I'm standing, you do it standing, put your thumb out, and they're gonna go side to side like that. And you do that 6 times. And you're gonna ask them how they feel after that. This will probably elicit symptoms even if they don't have a concussion on the sideline because they have adrenaline going. So if you are looking for evidence or proof or something to support your decision to keep someone out, you can use that. The VOMs is really, the VOMs is a great tool. It is very effective in predicting concussed patients. So it's about 90% accurate when you look at the VOR, the last 3, near point of convergence, VOR, and VMS. And again, that was really quick. I am happy if anyone is interested in learning more about that, just you can reach out to me and we can set you up. You can come in and learn. I'm happy to do that. So this is kind of the whole path. You know, we start with pre-existing risk factors, understanding those, understanding the details of the injury, determining their clinical profiles, and then prescribing very specific treatments that are going to attack those present profiles. You know, we used to think that most people were going to recover in 7 to 10 days. I actually just read an article that was published last year that still referred to that. And we know now that recovery takes longer. So we're seeing 14 to 21 days in adolescents and up to 30 days in kids. That's pretty consistent. And females take longer. They consistently take longer than males. So recovery is going to depend on their individual risk factors, how severe was the injury, the type and timing of treatment. So are we seeing them in our office 1 to 2 days after injury, or are we seeing them in our office 2 to 3 weeks after injury? Because that's going to play a role. And then were they removed from play? So there's some pretty good research that says the longer they stay in play, I mean, 3 minutes staying in play after concussion, they could have a much longer recovery time. This article just highlights the need for multimodal assessment. So published in 2019, they took 17 athletes, 64 concussed, 59 control, gave them a PCSS, impact, VOMs, and BESS. The idea was to see what, if any of these were predictive of concussion. So significant differences between the concussed and non-concussed groups were found with the symptom score, their memory scores on impact, the VOMs, and specifically the near point of convergence measurement. And significant predictors included the symptom score and VOMs. So what I want to highlight here is the best was not predictive. So we really don't do balance testing unless there's indication there's something structural going on with their peripheral vestibular system. Balance testing isn't going to be that effective or effective at all. And so those two predictors correctly classified 85% of the total sample, which is pretty good. Looking at the modifying factors, so demographically, we know there are sex differences, we know there are age differences. In terms of post-injury factors, I'm going to talk briefly about these two. So in terms of sex differences, this was a paper from 2017 that was really just a nice meta-analysis looking at, oh, sorry, this was not the meta-analysis. I was thinking of something else. This was a study looking at 224 athletes ages 13 to 17, looking at sex differences in between males and females. They found that female athletes had greater neurocognitive decline and increased symptoms as compared to males. 74% of female athletes exceeded reliable change on their neurocognitive testing. So their scores were significantly below where they were at baseline versus 59% of males. And 30% of those females had a protracted recovery, meaning the recovery took 3 weeks or greater versus only 13% of males. So those differences are very real. In terms of the modifying factors, so this is an old study now, it's 10 years old, but it's still one of the most important ones I think that's been done to date. Looking at what signs or symptoms on field are predictive of protracted recovery. And so the number one was dizziness. And this includes kids who are vomiting on the field. This includes kids who had lost consciousness on the field. On-field dizziness, those athletes have a 6.3 greater risk for having a recovery that's going to be 21 days or more. So always ask about dizziness. That's one of the questions I ask every single time. Did you have dizziness at the time of injury? And then post-traumatic migraine is also going to be a modifier. So post-traumatic migraine is not just a headache. If you have post-traumatic migraine, you also have sensitivity to light or noise or nausea. And if that's present versus a group that has no headache at all, those kids are going to be 7.3 times greater chance of having a protracted recovery than not having a headache. So there really is something about those migraine symptoms. And interestingly, if they have post-traumatic migraine versus just a regular headache, they're still almost 3 times more likely to have the protracted recovery. Okay. I know we're running out of time. I'm almost done, I promise. This is the important part. Okay, so we always start with behavioral regulation. This is critically important. This stuff starts out of the gate. That's why we put it on that assessment tool. And so I give everyone all of my patients just a little blurb about it, but as athletic trainers, I really want you to understand why we're telling them to do these things. And I try to explain this to the athletes too, because if they know why we're asking them to do it, there's a greater likelihood they're gonna do it. So let me just run through these. In terms of sleep, so after the first 48 hours, we're pretty strict about saying no napping during the day. And so sleep is going to be the foundation of recovery. If they're not getting good sleep, they're not going to recover, period. And there's no magic number of how much they need. But if they're sleeping too much, they're not getting the right kind of sleep. So in general, teens need about 9.5 hours. Most of them don't get them. I saw a girl today, I think she was 14, and she gets 5 to 6 hours per night because she's doing homework all night. But when they're cycling through their sleep cycles and they're hitting that deep, slow wave sleep, that's the magic for concussion for any of us, right? When we're hitting that deep sleep, that's when we are re-energizing our body cells. It's clearing waste and toxicity from the brain, supporting learning and memory. We only spend about 20% typically in deep slow wave sleep. And every time they're sleeping during the day, they're messing up their circadian rhythms and they're not getting that deep sleep. If I could put a Whoop or some kind of tracker on all of my patients, I would love to see the data. But we know that when they're napping, their quality of sleep just isn't great at night. And if they sleep too much, they're more tired. This dysregulation is just all contributing. So after the first 48 hours, we're pretty strict. They sleep at night only. If they need to sleep during the day, 20 to 30 minute cat nap before their brain starts cycling. Hydration, we recommend half their body weight in fluid ounces of water per day. Most athletes I see tell me they drink a ton of water, and then I give them that metric and they're like, wow, I don't drink nearly enough. We know that the brain is 70 to 85% made of water, and even 2% in dehydration can cause cognitive difficulties. That's in a non-concussed population. So when you have a concussed population and then they're dehydrated, that can increase their cognitive or their perception of their cognitive difficulties. So in addition to trying to reduce their headaches, we want to make sure they have optimal cognitive functioning, and it also helps to improve the circulatory system, and that's going to help the brain to heal as well. So really pushing that they're drinking at least half their body weight in ounces of water per day is important. In terms of nutrition, the most important thing I emphasize is maintaining adequate calories. So the quality of calories isn't as important as making sure that you're taking in calories. This is especially important if they're feeling nauseous and they don't have an appetite. I explained to them that calories are energy, and your brain is in this constant state of energy crisis. And so we need to fuel the brain in order for it to heal. They can modify the diet. They can do shakes or smoothies or crackers if they have to, if they're really nauseous. If they can, we'd like them to increase their protein intake, make sure they have protein at each meal, and limit sugar and caffeine, encourage whole foods. I mean, it's hard with teenagers, but the more that they can eat whole foods, the better. That being said, this is not the time to go on some drastic change in diet. I have had some parents that have asked me about keto diet. This is not the time to put your kid on a keto diet, obviously, if we're trying to get them better faster. In terms of exercise, so there's a lot of good research out there on exercise. We're doing some, which I'll tell you about in a second. In terms of concussion, after the first 48 hours, we're asking our patients to walk. Take a walk every day, ride a stationary bike if you can, do some stretching. We know that moving your body is going to improve blood flow to the brain, which is going to help improve autonomic nervous system balance, so pulse, respiration, things like that. It's going to upregulate BDNF. So BDNF is brain-derived neurotropic factor. That is like miracle grow for your brain. It helps brain cells to heal. It's going to improve your mood. It's going to improve your sleep. It's going to make you feel better. And then we really try to limit stress. So when you're experiencing stress, your nervous system is activating fight or flight, and you're in this constant state of arousal. And when you're in that constant state of arousal, that takes a lot of energy. And so all that energy could be used for healing is now being used to be stressed out. So we really try to counteract stress, encouraging meditation apps. We can teach deep breathing, recommend therapy or coaching if that would be helpful, but usually integrating that daily walk, giving them academic accommodations that really focus on the individual. We tailor them very specifically. That can help counteract that stress as well. Okay, so to wrap up, I just want to give you a little taste of what we're doing from a research perspective. We have started our research program. We have a research registry, and we're doing some cool things this year. So this project we started last year. The question was, having the vestibular therapist in the clinic, does that really help our patients get better faster when we can get them into vestibular therapy faster? So we have two groups of athletes. They both had positive vestibular findings on bombs. And we had the athletes who started vestibular PT within the first 10 days following their concussion, and athletes who started after the first 10 days. And sure enough, the results revealed that the late group was 7.5 times more likely to have a protracted recovery. The caveat to this is we don't start vestibular PT until they're on at least day 8, usually, just because they're too symptomatic before that. So these are really kids who were seen on day 8, 9, or 10. So clearly, the earlier we get athletes in, the faster they get better. And we're hoping to have some more data for that project soon. We also have a grant from the Ray H. Marr Foundation, which is really exciting. We're doing a 2-part study, and we're going to be enrolling people this spring. So watch out for some advertisements for this. The first part of this grant is we are in the process of developing with our exercise physiologist, Caitlin Brown, a new submaximal dynamic exertion test. So for those of you who are familiar with the Buffalo treadmill test, that test is really designed to assess for autonomic dysfunction after concussion, and we really want to add in a dynamic component to start looking at some of the vestibular system and some other things that we're missing with just looking at autonomic. So to start testing this, we're starting with healthy participants. And we want to see, can we safely exercise concussed patients up to 80% of total capacity? And what symptoms did they get at those stages? We're starting with healthy controls just to see what the healthy response is. So the goal of this study is to determine normal symptomatic tolerance in the healthy population. The second part of this grant is the cognitive piece. So we are partnering with Sports Academy as our performance group in the facility, and Sports Academy Venture Lab does cognitive performance training. So for example, they outfit Complexity Gaming in Frisco, which are all the eSport athletes. Their cognitive performance training platform is awesome. And we want to know if we can use it for concussed patients. So we're going to study the impact of early cognitive training in concussion. And this, again, is based on that non-sports related research on neuroplasticity. We know there's something there. Can we modify this performance program to be applicable for concussion patients? So the healthy athletes that come in to do our exertion test will also be doing this cognitive battery this spring. All right, contact info. That's our clinic phone number, our website, my email address, Caroline's email address, and that's my cell phone. We're all professionals on here. I am fine with you texting me or calling me. I mostly get text messages. If athletic trainers have a question about getting an athlete in, please don't give that to anyone else. But I am fine with all of you having it. And I would encourage you to reach out to me at any time. If you have any questions, if you want to come see the clinic, if you just want to learn more about our program, we are here to support you. And we really value athletic trainers. Like I said, I can't do my job without them. I consider you all my eyes and ears outside of the clinic. And so I really am grateful that you guys are all here and that you're engaged with all of this. Okay, this is the last slide. I close all my talks with this. This is mostly for parents and coaches, but I just kind of want to plant this seed too. So the three takeaways that I want everyone that I ever talk to remember is that number one, concussion is a treatable injury. It is nothing to be afraid of. You just have to understand the steps to take when one occurs. Active recovery is key. We are not doing dark rooms anymore. And the sooner we implement active recovery, the better the outcome. And I'm a huge proponent for youth sports. I think the benefit of sports far outweigh the risk. And this is a conversation we have to keep having with parents and coaches who are, or not coaches, but parents and athletes who are afraid to engage in sport because there's fear of injury. It's really important from a developmental standpoint that they're able to do that. All right. Oh, just a few minutes over.
That was perfect, Dr. Reynolds. Thank you. We do have just a couple of questions for you. The first one is in regard to some of the new data that you were presenting for the effectiveness of the new assessment tool. I know you've collaborated with athletic trainers and other individuals that are important in the sports medicine model. Is there going to be any efficacy of the use of that sideline assessment in comparison to, say, something like the SCAT, which we're all very used to doing?
That's a great question. So we hadn't thought about that, but we could do that because we now have a research program. This was, so in my work with the NFL, this year we stopped using the SCAT 5 because the SCAT 5 has actually not been validated. So it's the first one that has not been validated. And so, the Cowboys said they weren't going to use it. And so I don't know where that is going, if they're going to validate it or if they're just going to wait till the next one or what they're going to do. But we could certainly look into that. That would be an interesting study. I'm actually going to make a note of that.
Awesome. The next question has to do with nutrition. You mentioned that the athletes should be eating whole foods. They should definitely intake more of the amino acids from their proteins. Is there any efficacy in increasing omega-3 fatty acids in their diet when they're in this active recovery phase of a concussion?
I was just asked that today in clinic. So I don't typically recommend using them for several reasons. Number one is the research that's out there is looking at long-term use. So in the short term, and concussion recovery would be considered short term, there isn't good evidence at all. And I find that it can upset their stomach. So the kids who I've seen who have been started on like a variety of fish oils, they just don't feel great on them when they're concussed. So what if you're going to do supplements? And I certainly see some doctors that still prescribe fish oil. I don't see that the point of it. If someone is having headaches, we try to limit their over-the-counter pain meds to only like 1 or 2 doses a week, and that's even Tylenol. So for the first couple days, it's fine, but then we get kids that just take it, and they get these rebound headaches. I often recommend a combination of magnesium and vitamin B2, which is also called riboflavin. And magnesium and B2 are taken from the migraine literature, and I find those to be much more effective and tolerable as opposed to doing something like the omega-3s.
Great, thank you. That was great information. Let me see, it looks like we might have one more question down here. All right, the next one, what does the exertion evaluation entail? And when is this indicated in the acute stage?
So, okay, that's a great question. So we probably wouldn't be doing it so I consider acute stage the first 7 days. The most we would do in the first 7 days is maybe have them on an exercise bike or have them walk and just have them track their symptoms. It's important information to know what's triggering them. Beyond that, it's really dependent on the specific athlete. So if they seem to be having more autonomic dysregulation, we would do something like a treadmill test or a progressive cycling test. And then Kayla, our physical therapist, will design a workout or exercises for them to then take back to their athletic trainer or to do at home to complement their recovery. If they're having vestibular symptoms, that's where this test that we're going to try to validate this spring is going to come in, because that's really going to look at the dynamic aspect. It's going to add in some agility and lots of movement in the horizontal plane that will help us determine what exactly is going on. So it's really, there's not one specific test that we do. It's really just seeing how they move and how they respond to movement.
Great, that makes a lot of sense. All right, it looks like that is all of the questions that we have. Thank you very much, Dr. Reynolds, for your presentation. It was very thorough and we do appreciate it. I will be sending out the PDF fillable for anybody that needs it. As Dr. Reynolds had mentioned, the Baylor Scott and White PRN athletic trainers, you have this available in your When I Work app. So this is available there, but if you don't have it, then please reach out and we'll get it to you. This is National Athletic Training Month. And so thank you guys for helping to be a propensatory moment in our athletic training history and doing what you do every day. Thank you for doctors like Dr. Reynolds and the other physicians that we have within our group that allow us to give that continuum of care. Be on the lookout for the post survey that will come in your emails. This way we can issue the CEU credit. And we do have the webinar recorded if anyone needs to have reference to it in order to go back and research anything. And so with that, I'll say thank you and good night, everyone. Thank you again for being on our call.
Thank you.